Thank you for coming. This talk is on integrated or whole person care for dementia. This is in fact the third out of 4 talks for the public given at BPP Law School. This one is on the 20th of August 2015. I'd like to first of all set the scene about why this is an issue. That if you happen to be one of the 850,000 people living with dementia, you're likely to come in contact with the health and social care services at some point, apart from your initial diagnosis, of course. Many people with dementia live with other medical conditions. It's a progressive disease of the brain, which can affect any function of the brain, not just memory. It's possible to live well with dementia, but to offer some sort of care and support for people with dementia, it's important to understand that many people, once they get their diagnosis, end up being rather alone. Some have their friends and closest friends desert them. Some people find it difficult to hold down a job. So it is a major life event for the people who receive a diagnosis of dementia. So the issue is who should best look after these people. And the next 50 minutes is going to give you an overview of the current policy in England. In a nutshell, the question is, if people become ill, how they can get help quickly, and if they need to go to a hospital, how to get them in and out of hospital safely. So the issue is whole person care or integrated care, and the major drive behind integrating health and social care is something called Parity of esteem, where physical health is on a par with mental health. In other words, mental health is no longer seen as inferior. I'm going to talk about the notion of person-centredness and talk about how to look after people with dementia, it involves more than one professional. There are 1 million unpaid family caregivers, to give you an indication. For the health and social care systems to operate well together, there needs to be some sort of functionality between them. That may involve data sharing within the bounds of what is necessary for confidentiality. And whilst this is complex, it is possible with the help of what's called collaborative or distributive leadership. There is involved some sort of care coordination, and nobody can quite reconcile themselves as to what the perfect solution is for integration of care. But 2 options may include the Better Care Fund, which was part of the Conservatives' manifesto currently being enacted by them at the moment, and Pioneers. And I'm going to mention self-management. Can be a controversial part of policy, but I will argue it is actually a necessary one, and many people do feel, for want of that awful word, empowered through self-management. Now, it happens that there's been a lot of management pervasiveness in health care systems across the world, and this is one such model of change. Now, not all change is progress, but if we are to move towards integrated care, most politicians agree that ultimately we're trying to move towards a rather bitty, fragmented illness service to one which promotes health and well-being, and this requires quite a lot of forethought how to do it. Now, the last government were criticised correctly or incorrectly, for a rather heavy top-down reorganisation. Ultimately, this will require some sort of re-engineering of the health and social care systems. Nobody's quite sure how. The problem with all the models is that it's hard to see how the models will all fit together into one national rollout. There have been many models across the years. Here is Cotter's change construct, which contains 8 steps. One is creates a sense of urgency. Now, to give you a clue as to this, the National Health Service currently has a 5-year strategy document called the 5-Year Forward View, and this identifies a number of gaps, including a financial gap and a wellbeing gap, and there's currently thought to be a £20 billion shortfall in how we reconcile deficit reduction with operating a health service. So this 8-step construct involves getting people on your side, demonstrating some wins, keeping going, and somehow creating a new culture. And this is a huge thing that the NHS will embark upon at some stage. It's had many false steps of the last decade. I'm going to argue how it's coming together for dementia. Now, in my particular field, dementia, there have been a number of policy documents. To give you warning, there's been probably one policy document a year, and this is the big one from 2009, Living Well with Dementia, a national dementia strategy. One of the co-authors was Shibley Rahman, who's chair of Dementia Brighton. But there have been numerous challenges, strategy documents. This one happens to be one of delivering better care research by 2015. And unsurprisingly, there was another one this year, projected until 2020. Now, thanks for coming. In fact, you'll be rather impressed to hear that you're one of the bigger turnouts for my talks, and thanks very much for coming. But I hope that any one person who learns a bit more about national dementia policy is a win for me. So, thanks for coming. It's a series of 4 talks, and I've so far given 2 talks on dementia-friendly communities, and this issue of how to best give people choice in policy. Now, there have been a number of attempts at this, human rights, budgets, that I've given a talk on this, so this will not be the subject of this talk. So, the ethos about this is the interest has been there for people. This computer will be going on a follicle zone, but the National Health Service tends to view people as a list of problems to be fixed or not fixed, or for somebody else to fix. And this is something which has been criticised heavily recently towards a move towards an assets-based model. Now, what this means, away from the jargon, is quite simply that when a person with dementia, or a husband or wife or son and daughter, goes to see a clinician, it's no longer a list of things that they can't do compared to last year, which is very demoralising for everyone. It's meant to be more geared towards how to best help that person live a better quality of life, and quality of life is a statutory outcome of the Care Act in Section 1.1, Part 1. So it's very important to national policy. I remember going on ward rounds a decade ago when a consultant would say, "Don't worry about him, he has dementia." Now, those sort of days have gone in public, but there's still a residual ethos that there's not much which can be done about dementia. This is, as I argue in my book, Living Better with Dementia, a residual facet of the medical model, in that there's no potent cure for dementia as yet, and symptomatic treatment is poor, can be successful, can be poor. So the ethos nothing can be done is very widespread, even amongst professionals. I will argue amongst other people that it is not actually true. So I don't really want to teach grannies how to suck eggs. This may be known to some of you, even if you can't read the writing, and if you happen to think this is a really awful slide, you're right, it is. But I don't want you to read the writing. But I'll read out some of these aspirations of I receive more care in my own home and the community, or my experience of a service matters to those who pay for it. And I have a real say in local services. Now, if you're wondering where on earth these came from the Sir John Oldham Commission on Whole Person Care, which reported to the Labour Party last year, and it had been the intention to legislate for this. One of the Labour leadership candidates is currently arguing for a national health and social care service, and this is also on the horizon of the current government. Its current Secretary of State has got his eyes on integration too. It just happens the Labour Party called it whole person care. There are some nuanced differences, but the policy narrative was long one. Here's a King's Fund from Nick Goodwin and colleagues of complex long-term conditions. The idea that, as a leading advocate recently passed away, Richard Taylor, said, I do not want to be considered as living with a fatal disease. I want to be considered as living with a chronic disability. Think about that for a moment. Dementia is actually a disability under the Equality Act Regulations 2010. So this requires reasonable adjustments, and certainly the idea that nothing can be done is actually unlawful under the Equality Act, because it is actually a disability. So the IPPR, which is meant to be an independent think tank, some people disagree, but came to the view through this excellent report by Bickerstaff that there's local enthusiasm for integration. The question is, how on earth do you build on the momentum? And it's been it never becomes a really major political issue compared to the deficit or other things, but it's been there rumbling along for ages. Not only is in the last election there were issues with delayed discharges, disparagingly called bed blockers by the popular press, people who through no fault of their own could not get out of hospital. The fault, in fact, was due to a social care service on its knees. So therefore, what happens in social care is argued does have an impact in the National Health Service, but the social care system merits attention in and on itself. It is a very worthy profession which is not just there to bail the National Health Service out of problems. So here's the figure for my book, which is rather noddy depiction of integrated care, but the issues more than physical health, mental health and social care is a number of other things like access to intelligent technology. Now, the current government's very keen on apps and smartphone apps and things like that, and some think tanks. Access to justice, well, there's no point having a law unless people can actually enforce it. Community-based resources, well, I've referred to these before when discussing dementia-friendly communities, things such as leisure and recreation. Education, well, the myth that people with dementia can no longer learn needs to be squashed for good. It's a very pertinent myth and very malevolent, and not true. People with dementia do want to learn new skills, and often do have to find themselves learning new skills to lead a different life to the one they used to be leading. Employment opportunities, financial well-being, housing, one of the social determinants of health, is linked with health. Now, Bevin used to be, or is it Bevin or Bevin? One of them used to be housing and health minister. I'm sure you will know which. But health and housing do go together, and there's still quite a big drive to get them close together in dementia policy. The built environment, in other words, having inclusive architecture to allow people with dementia to navigate themselves around. We were discussing earlier with Alzheimer's disease, people can have difficulty with signage and navigating. Therefore, the best solution is to make signposts more visible and transport. So I'm not going to really make this really laborious, I hope, but there are some policy constructs. Now, this is a figure from my book, but it's not really meant to engage you more than other than it maybe is a question of semantics we don't want to go into about whether we are persons, consumers, users, patients. I happen to believe that we become patients when we become ill, otherwise we're persons, but maybe this might be to analyse it through paralysis and unnecessary. But the idea is that there are some policy considerations for making whole person care work, and I've already identified these. Andy Burnham produced a vision for whole person care, and he said, whenever people are left in this disjointed system, some or all of one's person's needs will be unmet. So the Barker Commission from the King's Fund had provided new settlement for health and social care, and even thought about how it might be funded. And they thought there needed to be a much simpler way of doing it, far better integration, and brought up the idea of pooled budgets between health and social care. You will have heard of Diva Mank up in Manchester, which a lot of people are keeping a very close eye on. And I thought about London's Lounge being more closely related to social care. But be aware, there is a big debate about how you fund this, and some people believe that there's no need for top payments in the National Health Service. Other people feel this is an ideological portrayal of the health service, and it should be universal, free at the point of need. But as you will be aware, social care is means tested and has to be somehow glued onto a universal system, not easy. And there's been no solution from government about how to do this. So here's the older report again: one person, one team, one system. And the idea of parity of esteem, to give you some indication, has been rumbling on for ages. Lord Layard was one of the architects of it, a man called Alan Johnson, who's also dabbled at being Secretary of State for Health and Education, and their Home Office was involved with this. Norman Lamb from a different party, Lib Dems, was involved with this. And here's a report from 2013 from the Royal College of Psychiatrists asking for parity between mental and physical health. Now, as it happened, Andy Burnham said no more slogans after his slogan, make parity a reality. But as it happened, parity is not a reality because of the vast funding differences. And there have been a lot of do-good aspirations, mother at an apple pie. Here's one of them from the report, and here's another. I'm not going to read it out, but one of the major drives behind Parity esteem was to mitigate against the stigma and discrimination of service users, awful word, but users of the mental health services, which, as you'll appreciate, have experienced a massive shortfall in funding. And there's been latterly an emphasis that professionals working in social care as well as health need to be working more closely together. For example, your ability to recover from flu might be related to your state of mind. And there continue to be lots of reports about this. Here's one from ADAS, Towards Excellence in Adult Social Care. And they continue to have national priorities for excellence social care, having all authorities be locally accountable, having commitment to demonstrating outcomes, building confidence, clarifying the Office for Support for Organisations. And the idea that social care somehow keeps going despite the fact it's not being given money to do any of this is quite commendable. Now, Richard Humphreys of the King's Fund, he's one of the directors there, published this here article about integrated health and social care, euphemistically called Progress and Prospects. Now, here's something we all knew, that whilst the current government, which is the same as the last one, sort of, talks about ring-fencing of NHS budgets, the reality is it hasn't quite been up to the same level because demand has gone up. And the issue here is that none of the political parties want to address full-on the financial crisis that there is in NHS and social care. And Richard's very honest about this. But here's a headline from June saying 1 billion further cuts to social care will hit tens of thousands, say experts. And you'll be aware of the hoo-ha about the cap in care costs, which had been a promise of the Conservative Party, which they reneged upon. This is definitely unfinished business. So the idea would be to improve outcomes in health. This means improving better health, better care, improving how much the whole service costs. In other words, if you looked after people's health and well-being first and foremost, then you avoided unnecessary admissions. A difficult policy thing to argue, because we don't want to give the impression that anyone who ends up in a care home or in a hospital has been a failure of medical help. We do not want to give that impression. However, it turns out that it could be that some people are better off not being in hospital than being in hospital. And ultimately, it will cost less. And one of the main aims of the Health and Social Care Act is to reduce health inequalities. Now, you can argue that marketising the health and social care services doesn't reduce disparities, it conversely increases disparities. But critics of that argument tend to say that's not true and is ideological and not an issue. I mentioned earlier a man called Richard Taylor, whom we were sad to lose. He was a man living with dementia. He died about 2 weeks ago, dreadful loss, and he quipped about this fad we have in policy called person-centred care. What I'd like to know, he said, is if they weren't concentrating on the person, what were they concentrating on before? Now, actually, policy people may dismiss that as family-centred care or relationship-centred care, but the problem is, in dementia policy, we are suffering a bit from fashions and things which come in and out of vogue. There are some issues about a general consensus what might make person-centred approaches work. There's a number of things like when you go into hospital, my name is you're a person, not a patient, and your name is A-B, not B-A on your board, and it's the whole thing is about making the NHS more human. But people who one person-centred care is saying you can't deliver person-centred care if you don't look after the workforce in a person-centred manner. In other words, you have properly staffed wards, that you look after staff welfare, their health, and if they're not coping, you do something about it. Anyway, that I think is a very good argument. And a lot of these things are about looking after the views of friends and family. Friends and family find it unsurprisingly unsettling when one of their loved ones enters hospital, care home. So the idea is try to embrace them into care plans. And the idea about personalised care plans, look, I've heard a lot of criticism about them. I have no strong opinions about them. As it happens, in dementia, there's a number of us who believe that dementia quite hasn't been given the status of being a terminal disease like it should be, and that advanced care planning should be more of a priority than it should be. But even before the terminal phase of dementia, and many of us do not like the term phase or stages because it implies some sort of linearity of dementia that sometimes does not exist, that even if you're not totally moribund or about to hit the hospital or care or hospice, that you should have some sort of care plan in place to envisage that if you developed pneumonia, say, then this is what you're going to do. You're going to take a course of antibiotics. Or, say, if you happen to have one of the frontotemporal dementias, that your care plan might involve a speech and language therapist to help you communicate better, or something like that. Or if you have posterior cortical atrophy type of dementia, if you have a problem with 3D vision, then maybe a physiotherapist or OT can help you with your health, that sort of thing. So, yeah, the idea that you can't deliver personal care if you have regimented activities is one worth thinking about. That instead of having a drug round, you replace it with an activity. Now, of course, this is a highly institutionalized way of looking at things. People, when they go into hospital, view them as institutions, which they are. Now, some people argue that what I want from a care home is a home for me, and the people there are not working in my home, but I'm you know what I'm getting at. It's a difference between people working in your home or you living in their place of work. And the problem with care homes is that most people want to say that when I move into care home, this is my new address. In other words, it just happens it's no different from living in their own home in terms of stigma. It just happens to be a care home. But Anyway, these are very lengthy arguments. I'm not going to bog you down too much with them here. But the dramatist personality of people is an extensive one involving GPs, neurologists, geriatrists, psychiatrists, dietitians, OT, SALT, physios, neuropsych, CPNs, adolescents. Well, remember that I said there are 1 million unpaid caregivers, mostly husbands, wives, or sons or daughters. They need support. I don't like the word burden. A lot of them are under strain with financial and emotional aspects. A lot of them do find their work intensely rewarding. That's why you try to avoid the word burden. But some of them do need better coping strategies. And the quality of life of the carer is, and you can quibble about whether the word carer is the right word, but let's disagree on the word carer. The quality of life of the carer is intimately linked to the quality of life of the person with dementia and vice versa. So therefore, it's worth looking after the carer because that will impact on the person living with dementia, it is argued. Data sharing. Now, this has been caused no end of problems in national policy. As a patient of that service, you will expect a duty of confidentiality. In other words, you will not expect a doctor to talk about your illness in a pub, for example. That sort of thing. Obviously, that's one extreme example, which will involve a regulator. If there are cases of abuse, safeguarding reasons, this information would have to be shared to protect the person. So you can see there is a conflict between confidentiality and disclosure in the law, and this is no less important than NHS. And many of us have been totally mystified why there's no unified electronic patient record. In other words, if your GP prescribes a drug in the morning, that information should be available, one would argue, to admitting any doctor in the afternoon should something go wrong, say if there's an adverse drug reaction or something. Or say, for example, if a person moves into care home, why should there be a massive, almost like a Chinese firewall of information preventing health professionals from knowing what their previous illnesses were in the past? This puts the current staff at a massive disadvantage. So anyway, this is rumbling on and on and on, and the current government made it available. You made your electronic patient care record available to you, apparently. So if you ask your GP, then if you quiz them about it hard enough, they'll tell you how to find your own personal care record, and that has been a drive of NHS England. The idea that if you know something about what's written about you, for example, then you may be better informed to take part in shared decision making. But this has been really painfully problematic policy. Caldecott, as you'll be aware of, the Caldecott Gardens, talks about a duty to share information and watch this space, whichever way whole person care or integrated care go towards. Data sharing is a big part of it. Now, this is not without its politics, as you will be aware that there will be quite a lot of interest to make sure the information does not go into the wrong hands. For example, something which happened to you at the age of 10 or 12 or 16 should not be prevent you from taking out insurance, or should not be a cause to make your life insurance sky high due to some family history of Alzheimer's disease, for example. Anyway, big policy punk, far too much to discuss here. And you'll be aware that there's been a flurry of care data, and I'll let you Google the covered, or just look on Twitter and you'll see it immediately, current issues about how all this data is going to be uploaded into some central government database on some sort of presumed consent basis. So the critics worry about. Whoever takes whole person care or integrated care further is going to have to do things right in a very strong way, and this might be in terms of, say, a charismatic leadership approach where you set a plan and stick to it, a vision, stick to it, or it runs into problems and you negotiate with one form of leadership, or you have transformational outcomes. But anyway, I'm not going to bog you down in the leadership literature, but needless to say, given there are all sorts of leaders popping out of every orifice in the health and social care systems, it makes sense to look at them as a distributed neural network of different leaders in different places who can motivate change, back each other up, inspire people, and produce operational synergies and strategies to make it work. And that, of course, is the theory. Whether anything works in practice is your guess as normal. Anyway, the Kids Fund have been quick off the block to produce reams of stuff about collective leadership, and this is actually very interesting. He is such a complex soup of integrated care. Who's going to drive it? Now, some would argue the best person not to drive it is the Secretary of State for Health, who can command fans and enemies, so he may not be the best person. So anyway, here's the theory: collaborative distributed leadership. There's an ability to share control and decisions, consolidating shared intelligence, furthering trust and confidence. Well, obviously, leader who doesn't inspire any confidence is going to be shown the door fairly quickly. Maximising human resources. Well, I think it's more than that. It's maximising resources, full stop. Say for some, training for doctors far outweighs training for social care workers. Now, the budget, for example, Skills for Care, is a fraction of the budget for health education in England. How on earth are you going to deliver, it is argued, parity esteem if you have such a major disparity in training budgets between the two professions? And part of the issues always has been problems with power, who often jokingly called, does the GP send the consultant a bottle of wine for Christmas, or does the consultant send the GP a bottle of wine for Christmas? And who has the power? There have been a number of ways in which policy has tried to get around this, one of which is person budgets, which has been sort of giving money follows the patient type meme with limited success. Some people, as you will be aware, have argued against person budgets as being a sort of microcosm form of rationing. You can't develop optimal care if you don't give people the money to do so. Therefore, you have no power. Anyway, distributed is argued. Distributed leadership enables innovation, handles conflict, and handles collaboration. Now, you'd be aware of Section 75 in the Health and Social Care Act, which put a duty, if there's more than one bidder, for there to be a competitive tender. Now, whether or not you agree with Simon Stevens, the head of the NHS, or not on this, is somewhat by the by, in a way. It's thought that alongside competition there has to be some sort of integration or collaboration. And I think it's tricky because whichever contracting model you have, somewhere in the mix is going to be physical health, somewhere in the mix is going to be mental health. And here's something to think about. According to the article in the first paragraph, in the general population, at least 25 to 30% of general medical patients have coexisting depressive, anxiety, somatoform, or alcohol misuse disorders. Integration without care coordination, most people really won't work. And the details of the slide for the King's Fund aren't that important. Suffice to say, it could be one provider doing really well to coordinate different operations within it, or it could be multiple providers acting really well to harmonize their operations between each other. Now, you may be aware of something called the care program approach, which does involve care coordinators. There are certain conditions, such as recent discharge from the Mental Health Act or substance misuse, or there's criteria for being part of this program. But anyway, part of this program will involve you having a care coordinator and a care plan. And you can take your pick as to what source of information you want to learn about care coordinators. There is general consensus that some people think they could be non-medical entities, other people think they could be GPs, so or could be close family friends. They manage a care plan, manage out-of-hospital support. Now, it's been increasingly of concern that discharge planning tends to be rather last-minute ad hoc, and the idea that once you get people out of hospital, they should have something a bit more elegant to live their lives by. Maybe a care coordinator will be involved in that. Integration of pooling information. One of the biggest concerns about having multiple providers is that you reduplicate many tests. You have the same test again and again and again. And if you don't have a universal care record, you won't know what tests you recently had. I've known people who have ECGs almost daily because there's been such lack of coordination between providers. And the details of this slide are important, but here's what the King's Fund thought might be characteristics of successful approaches to care coordination. Now, I'm going to conclude in the last few minutes with some of the exciting developments in integrated care. Now, this is currently in the Conservative Party Manifesto 2015, meaning that it should be carried out by 2020. Now, the Better Care Fund, King's Fund and all that, has been involved in giving people budgets to come up with solutions to integrate better health and social care. There's been some brouhaha about whether this is new money. The consensus is that it's not, and I'll leave you to read about the details there. The alternative approach, before I go on to this, is vanguards. Now, I was explaining earlier that these vanguards, rather hyperbolically called vanguards, now, this is a new innovative way of doing things, which are nest beds of good practice which may or may not work. They're experiments. We've been through these experiments before. They may work, may not work. Pioneers leading the way through testing new approaches like new commissioning, new payment methods. I'd like to say something about payment methods. Currently, the health service pays people almost rewarding failure. Almost, if somebody's really badly managed, say a diabetic who has a toe transplant, amputated, or a renal transplant, or nerve neuropathy, then all these professionals will get paid to look after this person's illness. Now, some will argue that the money is better for being spent in general practice, where you can better manage people's healthcare ab initio in the first place, which is a better outcome. So, anyway, pioneers is one approach that's been taken, and here are the details, which is more or less in line with everything I told you about connected care, whole system redesign. And with whole system redesign comes whole system regulation, which can have its advantages and disadvantages. The problem with alliance contracting, sharing risks, pooling resources, that if anything does go wrong, then it's less clear who's at fault and who's to blame. But the idea is you're getting away from blame culture. On the other hand, some people do want a strict line of accountability if things do go wrong in the health service. And an emphasis on prevention and self-care. Now, that's what I'm going to conclude with self-management. The idea that you can encourage people to live better is felt fast from all the previous mutterings from our service, and a more positive way of doing things where you can make adjustments to people's housing to make their living standards better, or give them advocates if they have problems expressing decisions through independent mental health advocates or dementia-friendly communities or dementia-friendly environments. Or if they say, take this, a urinary tract infection, scenario A, nursing home, blood filling up, midnight, 1 in the morning, 2 in the morning, 3 in the morning, 3:30, blue light emergency, acute admission, can't quite get to the start, develops urinary tract infection, older patient, then gets acutely confused, then falls out of bed, and now has a fracture of the neck of femur, awaiting orthopedic referral, waits a week, develops a hospital-acquired infection, passes away. Now, obviously, this is not a correct scenario, not a very common one, I hasten to add, but it could exist. The alternative is if somebody is spiking in fever and is singing in urine or has a clarity catheter bag, then maybe practically this sort of thing could be sorted out 2 in the afternoon rather than 2 in the morning. And here's the case of a care home, but it would be the same in a in the community, where if somebody I know somebody who lives with dementia and also has chronic obstructive pulmonary disease, and he knows that when he develops a cough and when his sputum changes colour, then it's likely, unless he averts it, he's going to need a hospital admission. So he will see his doctor, who will or will not prescribe him a course of antibiotics. Now, that's far preferable to acute hospital admission of a week of intravenous antibiotics, for example. But on the other hand, there will be critics who argue self-management is nothing of the sort. It's just a case of shutting down hospitals, transferring things to the community in a cack-handed, underfunded way. There's no such money following the patient at all. There's no infrastructure of community nursing. And in the aim to have a smaller state is just a cover for cuts, and it's all a bit shifty and is really just a political statement. So I'm not going to encourage you to work out what you think self-management policy is about. Hopefully you'll see there are some meritorious aspects to both arguments, but possibly the way I presented them have been presented at somewhat extreme versions of self-management. But I would strongly urge you to look at self-management, self-care, across the whole long-term conditions policy base, particularly relevant to me in dementia, because it tends to be the case a lot of people who enter hospital with dementia, particularly with more progressed dementia, tend to do badly because they get very confused where they are, find the change environment distressing. Sometimes in hospitals don't even have allowed their carers coming in with them, and so really have a very unpleasant experience. So on the other hand, not to dismiss the valuable work done by my colleagues in secondary care, who are also doing brilliant work looking after people across the board, including with dementia. So I'm not going to read out this list to you, but here's some of the, not to flog the book, but a phenomenal living better with dementia, and there are, if you want to read more about this, this book will act as some lecture notes for this talk. So, House of Care, you will have been probably aware Barbara Young, Chief Executive of Diabetes UK, talking about Year of Care. I gave the example better diabetes care might be better in the long term. There's actually, in fact, a year of care for diabetes. Some of us would have liked this to have happened across the board, including for dementia. It was, in fact, a plan from one of the parties, not saying which, avoiding being political, but anyway, that was scrapped. But anyway, year of care would have been a way to give somebody a budget for a year to encourage all these things like self-care, self-management, a more proactive way of assessing people, not targets, but assessing people whether their quality of life had improved or not. So the care models and financial models for planning care and support are quite a big deal now, and I'd encourage you to think about how it's going to be delivered. Now, the reason why I did mention the fact the health service is rewarding failure is because the alternative view is that you give each person in the population a set amount of money spent to promote their well-being. That's called capitated payment to promote well-being, which might be a better way. Or I don't want to get into the issues about incentivizing people in a policy. We've had a few cock-ups of our own dementia. But the idea that instead of promoting illness, we should be promoting well-being. And there are various initiatives. Here's one: care improvement works. And the regulator obviously has to be involved. The economic regulator of the health service is the thing called monitor. CQC, by the way, inspect care homes and have a clear regulatory function there. But monitor have a duty to make sure integration is happening in the most fair economically, in the most fair manner possible economically. And they think this should be across the board. Early intervention, prevention, you'll be aware that is a major driver of public health policy at the moment. Self-care and promoting independent living. Now, I did mention this in an earlier talk. Independent living is not the same as living in isolation. The aim about dementia-friendly communities was not to make everyone living on their own, making them even more lonely than they would have been. The aim of it was to encourage a community which they could feel welcomed to lead a life. I hesitate saying productive life, meaning that I think it's perfectly possible to live a good life without contributing millions of pounds to the economy. The problems with using words like successful and productive, it makes it sound somewhat like an economic transaction of every citizen in the country. And independent living is quite the reverse. It's simply promoting well-being in the form of a person with dementia and care in a supportive community. So, in the last hour or so, I've tried to give you a rather naughty overview of the current state of play in my area, which is dementia, which will be obvious to you by now, of where we're at in whole person care, integrated care and Parity esteem. I've argued that this involves treating everyone more than patients who get ill, but who happen to be persons who do get ill, but whose also well-being is to be promoted. And the idea that their health is all in the hands of GB is now a bit out of date, and it involves a lot of sharing of information. I prefer the word information, data, by the way, amongst various entities. And with such a vast network of people involved, the only way to have leadership, I've argued, by the way, the people who should be showing leadership in policy are the people with dementia and carers, but that aside, is a distributed network of people. In other words, not just one Secretary of State for Health who's in charge of leading this Uber organisation. Current Protestant plan have been the Better Care Fund and Pioneers and Vanguards. There's been a lot of hyperbole about these, but I wouldn't get too excited unless there's some sort of reliable, sustainable rollout of this in future. And whichever way pans out, self-management will be a critical part of policy. I'll leave it there. The last talk will be on cure, care, or research, which are the bigger priorities in dementia policy. And if you can join me for that, you're more than welcome. Thanks.